I'm going to hand over to Dr. Jack Meintjes, who's going to give us a brief overview of the latest literature in hyperbaric oxygen therapy.
Okay, so I've been asked to just give a brief overview of the latest literature on HPO, and it's not a blanket free for all. What are all the things that were published in the last 3 or 4 or 5 years or so? It's basically just to look at where we currently are in terms of the indications internationally. So what are the approved indications and the latest consensus around that? And then with a more of a focused approach on the use of HPO in the context of the COVID pandemic. So to start off first with the UHMS indications, obviously the last publication is the 14th edition. That was, if I remember correctly, 2019. And when you look at the indications, not a massive change, so still fairly similar from previous editions. What you would see here is when they refer to arterial insufficiencies, they talk about hyperbaric oxygen therapy for selected problem wounds. And normally problem wounds used to be a separate section all on its own, but classifying it as a part of arterial insufficiencies, I think those in wound care would appreciate that venous stasis ulcers and those sort of things are not typically managed by means of hyperbaric oxygen therapy. It is the compression bandages and those sort of things. So I think the list of indications just trying to ratify this fact that we're talking about some of the arterial issues regarding selected problem wounds. And then, of course, we're talking about the microangiopathies and not the major vessel occlusions and things like that. The others that you can see there, carbon monoxide poisoning, gas gangrene, etc., they basically stay the same. Sensory neural hearing loss has been included since the previous reviews, and then you can see the rest are basically still the same sort of indications. In terms of the ECHM, the European colleagues, so their approach is a little bit different. So they use the consensus conferences, and you can see that a significant change from previous consensus conferences where they now looked at the evidence, but also looking at the quality of the evidence and then the evidence synthesis, similar to what we would see with people doing the Cochrane reviews and so forth. So you can see then the levels of evidence. Level A evidence is where you've got at least 2 concordant large double-blind randomized controlled trials with little or no methodological bias. So those are the highest level of evidence that one would have. Level B is where you've got double-blind randomized controlled trials, but there may be some methodological issues or it's a small study and so forth. So level B evidence. C is consensus of experts, and then you can see the level Ds and so forth really not high up on the list of evidence. So based on the evidence, one would then make recommendations, and the levels of recommendations is a level 1 would be that there's strong evidence for the beneficial action based on the double-blind randomized controlled trial. So you can see a level 1 recommendation would go with level A evidence essentially. Level 2 is evidence of beneficial action based on double-blind randomized controlled trials with methodological flaws and so forth. So you can see the levels of evidence basically speaking to the level of recommendation that is made. So you can see that how the consensus conference then looked at this is the level 1 evidence. They said this is where we'd make a strong recommendation. So the typical wording that they would use there is we recommend that HPO be used for something specifically. Level 2 is a weak recommendation, so we suggest, and then level 3 would be a neutral one. It would be reasonable, and then no recommendation is if there's no agreement by the experts. So level 1 would be the course of action is considered appropriate by the large majority of experts with no major dissension, and we are confident that the desirable effects of adherence to the recommendation outweigh possible effects, undesirable effects, while the weak recommendation is that there is some degree of dissension ascension exists among the panel, and that adherence will probably outweigh the undesirable effects and so forth. And then you can see the level of evidence, the grade system that we've mentioned earlier as well. So this is where we are. When you look at the levels of evidence, we've actually got high levels of evidence, so A-level evidence, with strong agreements for these indications. So these are the type 1 recommendations. It's actually quite difficult when you look at these things and the latest publications, for instance, on carbon monoxide poisoning and so forth, and you can see that there's a move towards drilling down to the more nitty-gritty. So overall, carbon monoxide poisoning, very strong agreement, and an indication that the benefits far outweigh the risks. But some of the minor issues, like those that we've discussed today regarding neuropsychiatric delayed presentations and so forth, those are things that still need to be fleshed out. Open fractures with crash injuries, osteoradionecrosis after dental extraction. So just note how these things are separated. So dental extraction, osteoradionecrosis of the mandible, and then soft tissue radionecrosis, cystitis and proctitis, and your sudden deafness, high levels of evidence for those indications. Level B evidence, decompression sickness, gas embolism, and anaerobic infections, as you can see over there. When it comes to the type 2 recommendations, there's A-level evidence and strong agreement for diabetic foot lesions and femoral head necrosis, and then level B evidence for your compromised grafts and flaps, central retinal artery occlusions, crash injuries, osteoradionecrosis of bones other than the mandible, and then other soft tissue issues. So if we're not talking about radiation, cystitis and proctitis, then the level of evidence is B-level evidence, not A-level evidence like for cystitis and proctitis. Surgery, so preventative treatment in a radiated area, ischemic ulcers, refractory chronic osteomyelitis, burn wounds, and the neuroblastoma, nematosis, cystoides intestinalis, those are all B-level, and you can see the agreement, strong agreement with the top ones, and agreement at the ones with the other B-level evidence. The type 3 recommendations, where it is sort of unclear, so we're not 100% sure, and that it might be reasonable, those sort of things. So brain injury, so acute and chronic traumatic brain injury, chronic stroke, and post-anoxic encephalopathy in highly selected patients. And I think once one starts treating these patients, it's important to look at the selection of these patients and how one decides, because there's quite a lot of detail in terms of the imaging studies and looking at the discrepancies between function and perfusion and so forth, and then deciding which patients may benefit. Radio-induced lesions of the larynx and CNS, post-vascular perfusion, so ischemia reperfusion syndrome, limb replantation, sickle cell, interstitial cystitis, etc. Those are all type 3 indications that would be on the list. Now, there is D-level evidence for these list of things, so post-anatomy mediastinitis, malignant otitis externa, acute myocardial infarction, retinitis pigmentosa, and Bell's palsy. So basically what we are saying is that there's no evidence for these things. We're talking about D-level evidence, so it is case studies, case series that are published there, but there are absolutely no trials that systematically evaluated these things. And therefore, we've got agreement that we recognize these studies, but we can't make firm recommendations based on the science of this. But then we also see recommendations where we've got B and C level evidence where we say hyperbaric oxygen therapy should not be used. So we've got B level, so randomized controlled trials that shows that HPO does not work for autism, placental insufficiency, multiple sclerosis, cerebral palsy, tinnitus, and the acute phase of stroke. So with those indications, as I move around the world, I see a number of units still treating these conditions, but there's actually evidence that it should not be given. So just be aware of that. That's the consensus statement from the ECHM. So that's basically where we are, and I think there's a number of later publications that came after 2019, and I think the ECHM publication was also in 2017 or 18 or etc. So there's a number of publications that came out after that. So the evidence has shifted a bit, but I think there's still a lot of work to be done for many of the things that we give hyperbaric oxygen therapy. We still need to get higher levels of evidence for that. Then just as requested, a review of HPO in the context of COVID-19. So obviously, I think everybody around in this grouping is aware of the initial questions and hypotheses that were raised. So whether hyperbaric oxygen should be considered as a treatment for COVID-19. This is the editorial by Richard Moon and the UHM. And you can see that they talk to the issues of the low risk of injury, but then treating COVID-19 complications with hyperbaric oxygen therapy. People will even go into the details of the pathophysiological mechanisms and the link with ARDS and HPO to describe how it may be used. And here you can see, can it be a novel supportive treatment? So this is in the early times. You can see May 2020 that this was submitted, and they would propose HPO as a novel supportive treatment for COVID-19. At this stage, a lot of questions were posed to SAUHMA. People would often contact us and say, what are we planning to do, and so on and so forth. But very low levels of evidence. Obviously, at that time, it was based on first principles. Since then, and here you can see just another article. In this article, we discuss anticoagulation, suppression of inflammatory response, HPO in the context of severe COVID-19 and livedoid vasculopathy. So just more of the same. And then we started seeing some initial case reports coming through. So this was one of the first ones. HPO may be effective to improve hypoxemia in patients with severe COVID pneumonia. And you can see this is just 2 cases that were treated in China, if I remember correctly. And this was just 2 male patients, 57 and 64 years old, and both of them were severely shortness of breath, respiratory rate about 30 minutes, oxygen saturation lower than 93% at rest, and you can see all the other things there. So exclusion of pneumothorax, etc., etc. And then basically the people were treated once a day for a week, and then they looked at their self-reported symptoms, their oxygen saturation, arterial blood analysis, D-dimers, and so forth and so on. And what you can see is for both patients, they had an immediate relief of their symptoms of hypoxemia, which makes sense. So after the first HPO session, and then they were also remarkably relieved after 7 days of HPO therapy. And then they concluded to say that we need to do more randomized clinical trials in future. So these were the first sort of approaches to patients with HPO therapy. As we carried on, you can see hyperbaric oxygen therapy preventing mechanical ventilation in patients. So a retrospective review of a case series. And here you can see 5 patients, again, just small numbers. All the patients had tachypnea and low saturation despite receiving high FiO2s. HPO were added to prevent the need for mechanical ventilation, and they used the standard dive profile, 10 meters, 90 minutes, and patients received between 1 and 6 treatments, and 1 of the 2 dedicated monoplace hyperbaric chambers. And then you can see again here, all the patients recovered without the need of mechanical ventilation. and a small sample of patients. So again, large studies are needed to define where we're going with this disease. So this is the time when people are starting to call us and ask for more information, and all the hyperbaric organizations around the world actually published position statements from the UHMS and SPUMS and so forth. And you can see some further hypotheses and proposals then coming forward. So what are the physiological and biochemical rationales for treating patients with HBO therapy? And you can see that, and this is reviewed by John Feldmeyer. So at that time, 11 studies were designated to investigate the impact of HBO2 on patients with COVID-19. And this paper then describes the promising physiological and biochemical effects of HBO and potentially in other disorders with similar pathological mechanisms. Another review that was done by the colleagues at the Karolinska Institute in Sweden is when they reviewed all these things. You can see again they talk about these anecdotes where there's compassionate use and 2 published case reports, as I've shown earlier, that showed promising results. And as a consequence of this is that they started small prospective clinical trials on the way, and they are then conducting a randomized clinical trial. And this is the type of approach that we want to see with hyperbaric oxygen indications. So this is then the randomized control open label multi-center clinical trial to explore safety and efficacy of HBO for ICU admission prevention, morbidity, mortality in adults with COVID-19. So this is not a publication of the results. This is actually the protocol that they've published. And this study is still ongoing. And basically what it means is that persons will come in, they will be randomized to either receive the best practice or best practice plus HBO. And they aim to have 100 people in each group. And the persons would be evaluated at baseline and then basically daily for a week. And then you can see day 14 and day 30 at the end of the trial. You can see, and then the treatments will be distributed evenly, but with adding HBO to the intervention group. So that's a promising study that we need to keep our eyes on for future publication. Some of the other clinical studies. So hyperbaric oxygen therapy for COVID patients with respiratory distress, treated cases versus propensity matched controls. So this is, again, a single center study that was done in 2020, as you can see, and they then placed the patients at 10 meters, 2 atmospheres absolute in the monoplace for 90 minutes, and a maximum of 5 total treatments. And then the controls were propensity score matched with COVID patients admitted in the same time period, and then they compared the 2 groups. And there you can see when you look at these comparable patients, they estimate the adjusted sub-distribution hazard ratios within 0.37 and 0.26 for mortality and ventilation respectively. And as you can see, the mechanical ventilation one reached statistical significance, but not the inpatient mortality wasn't statistically significant. So although limited by the study design, the results showed some safety in hyperbaric oxygen therapy, and it strongly suggests the need for a well-designed multi-center randomized control trial. So again, this is then what the published literature has said. So since then, there's been a number of reviews, again, to look at what is the evidence and what is the current status. Study from Japan, looking at various case reports. So you can see the case reports with the small numbers of patients, 5, 22, 1, and 5, and so forth. The typical treatment you can see is 2 atmospheres, 1.5 atmospheres in the GUE study. and none of the patients with COVID-19 that were treated needed a ventilator. Hazard ratios, this is the study that I referred to previously. Dyspnea and shortness of breath were immediately alleviated, the other study that I've shown, and hypoxia was improved. Hypoxia and symptoms were improved. So again, you can see not high-level evidence that we see from the studies. This is a systematic review that was published earlier this year. And what they basically shown is that overall HPO seems to be safe and effective. But again, as you can see, further explanations require extensive, well-designed studies. And there was 8 articles from 3 countries in this study looking at the results over there. And then this was published just a month or 2 ago, if I remember correctly, I think in the September edition of Diving in Hyperbaric Medicine, where they again evaluated the evidence for HPO in COVID patients. And here you can see 6 publications met the inclusion criteria, 37 hypoxemic patients treated with HPO. Of the 37 patients, the need for intubation and mechanical ventilation in hospital survival were assessed for 26 patients across 3 studies. Of the 26 patients, intubation and mechanical ventilation was not required for 24, and 23 patients survived. No serious side effects, etc. So you can see again, this is where we are. This is September this year, just a month or so ago. Limited and weak evidence from non-randomized studies, including 1 propensity matched cohort study, suggests HPO is safe, and it may be a promising intervention to optimize treatment and outcomes in hypoxemic COVID-19 patients. Randomized control studies are urgently needed. So that's basically where we are at the moment in terms of the study. So not a lot of evidence at this stage. There are a number of other publications also related to HPO during COVID, and that is regarding how do we manage our HPO facilities during COVID and managing the risk of infections when we have to put patients in the chamber, they're in close proximity and so forth. So managing all those risks are also discussed in the number of studies. This one, the evolving use of HPO during the COVID pandemic, you can see that they then describe a new approach that they had during hyperbaric oxygen therapy. So how do they do patient triage? They had to redesign the clinic. There was a change in the patient population that they were treating, obviously looking at high-risk patients and not exposing them to unnecessary risk, and also looking at the impact that it has had on their practice. And then Lowe et al. Looked at proactive COVID-19 infection prevention measures in a hyperbaric oxygen center. And this is actually quite a nice publication. It seems like we've lost our screen this side with load shedding again. Can I just get confirmation that people can still hear me on the rest of the chat? Okay, thank you. So this is quite a nice study where the people proactively looked at IPC measures in hyperbaric center. And basically what they say here is that as SARS-CoV-2 can be transmitted through droplets and aerosols, we cannot ignore the risk of transmission during HPO. And our center then prioritized prevention of spread and maintaining operation for patients during the pandemic. And the aim was then, so this article as to what is the protocol that they've used. And you can see here that they've got a staged approach depending on the epidemic level, and you can see the definition here. So first confirmed locally infected case in Taiwan versus first infected medical personnel confirmed there with them, and then first infected medical personnel within the health system, or third infected medical personnel, and so forth. So you can see they've got working groups, they've got a fixed care team that starts working in the unit. They limit the number of patients per dive so that they don't spread the infection. So if there's a low risk, then they can have more patients. And as the risk increases, they reduce the number of patients in the chamber. The total dive time is reduced in the higher risk areas, and then duration of the descent and breathing media, and duration of an increased partial pressure of oxygen, and then the ascent and breathing media. So all of these would be part of their protocol. They also mapped out in their chamber how they will do the seating to manage social distancing in the chamber. So you can see in the seating plan with A is level 0, where they would have 5 patients in the chamber, 1, 2, 3, 4, 5, and you can see how they space them with social distancing, and then 3 patients, and then just the 1 patient, as you can see over there, depending on the level of those things. Another study, the outcome of COVID-19 measures in Hyperbaric Oxygen Therapy Center during the pandemic. So they described a number of outcomes and what they've seen there, and whether they actually had cross-infections with patients. I think in this study there was 1 patient that presented with COVID-19 in association with the treatments, and then one of the other patients as well, but it seems unlikely that the transmission occurred in the context of the chamber treatment. But again, you can see a list of precautions that were done in the facility. So making sure that the seating is arranged, disinfection procedures, hand hygiene, etc., the things that we mentioned in some of the earlier talks and that Francois also spoke about. But again, I think just to make sure each unit should have an infection control policy and procedures in place to manage COVID and obviously other infections as well. This article by Takagi and also discussed disinfectant use, and they specifically also referred to hyperbaric oxygen therapy facilities, talking about the risks that we have concerns with flammable disinfections with oxygen and being in the enclosed space, or if you've got a gas-producing disinfectant in the enclosed space, that could be a risk. And then they also give a nice quick reference guide for disinfectant use. So the different options: UVC, ethanol, hydrogen peroxide, phenolic cresol, glyceraldehyde, sodium hypochlorite, formaldehyde, benzalkonium chloride. And you look at bacteria, envelope viruses, flammable or a toxic gas, yes or no, and you can see in the discussion over there, and the safety for human on hands and on wounds and on instruments, metal or glass and acrylic and the resin, etc. So this helps one choose the appropriate disinfection within a specific group of disinfectants. Obviously, for instance, if you look at benzalkonium chloride, that would be a good proxy for all the quaternary ammonium compounds that one can use for disinfections and so forth, as you know, is used commonly in the hyperbaric environment. Then there's also a short communication of a case where people have treated a patient for an emergency, and this was a carbon monoxide poisoning, if I remember correctly, in a patient that then required hyperbaric oxygen therapy, but also suspecting of possibly having COVID infection. And they then described their experiences in dealing with this, and a lot of issues are discussed. So implementing a workflow, coordination and patient transfer within the hospital, how do we protect staff, the in-chamber staff, the management of potentially infectious intubated and ventilated patients for HPO, as well as the environment and equipment. And you can see they give a nice list of different preventive measures. So minimize non-essential treatments and visits and so forth, the staff surveillance that they are going to do, the workflows that they implement. Prior to the patient arriving, there are certain things that they are putting in place. And then in addition to regular pre-HPO preparation, they also check the staff and make sure that everything is fine. And then for ventilated patients, there are specific risks because of the risk of aerosol producing procedures and spread of the virus via that way. To protect staff, the in-chamber staff, make sure that the people are experienced. They actually used full PPE during the entire treatment process as well. And then the out-of-chamber staff used N95 respirators, and the all staff shower and change their clothes before they left the complex, and then after treatment, etc. So you can see a whole procedure put in place. And what they say is when they successfully manage these emergency cases, the lessons that they've learned was that there was 3 main factors that contributed to their success. Firstly, there was this whole hospital-wide infection control precautions and practices. So they already had some procedures at the hyperbaric facility that they managed quite well, and that was already part of their daily routine. But then they also had an experienced person, so an infectious diseases physician or an IPC practitioner, to visit the hyperbaric facility, do the walkthrough and identify the risks. And in our experience, this is also what helped us, not in the hyperbaric setting, but in our hospital, is once you have experienced people that know how different isolation procedures work, whether you're talking about contact precautions, airborne precautions, droplet precautions, and vector-borne precautions, once you identify those risks and people that know how those precautions should work, then it adds a lot of value, because you can identify specific risk activities and specific risk areas. And thirdly, the team obviously doing the treatment must be well experienced, well trained, and comfortable in managing the patient in the chamber. And obviously in this case, they had to wear full PPE, which made it difficult, but having an experienced team obviously adds a lot. They say that some of the areas of improvement would be to do drills beforehand, because, and we know this with the chamber accreditation program that Francois and myself is involved, once people start doing emergency drills, that is where you identify some of the shortcomings, and when you do the dry runs, you can actually get the process much more streamlined and effective. So those are all the publications that I found in the literature pertaining to COVID. Are there any questions?
Jack, thank you very much. Thanks for a fantastic search and giving us that update on the COVID, because I think there was a little bit of sort of wondering where it's going to, because the initial study said no, and then it was yes, and then it was no again at one stage. So thank you very much for that. Yeah, so the question, of course, is how do we deal with this in practice? So if I had an HPO unit and I'm approached by somebody with COVID, so I would approach it by saying, that we don't have sufficient evidence. We're going back to basic principles. Make sure that one is au fait with those articles that are cited here that discusses the different mechanisms of action and how that interacts with the pathophysiology of the disease. And then one can, based on first principles, discuss the possible benefits and the possible risks with the patient, and then decide whether one wants to give the person a treatment. Obviously, there are a number of reasons why HPO would improve the patients, but there are a number of risks also discussed in the articles, and I think one has to have that objective view rather than just willy-nilly putting any patient in the chamber. Because as we know, the vast majority of people don't have a major severe illness and reaction. We're talking about patients that are severely ill, and then the question is, do you want such a very ill patient in the chamber? Can you manage that case? And what is the risk it poses to the rest of your operations? Any questions from the floor? Any questions from the platform?
So Edeline asked here whether there's any literature on the treatment of long-haul COVID, and the short answer is no, Edeline. So at the moment there are no publications. I'm also not aware of any publications of even case studies, but there might be some that I've missed. But I'm pretty sure that we won't have very high level evidence for this. So I would propose, if one deals with such a patient with long haul COVID, I would do a very thorough baseline evaluation, so that one can at least do a pre-post evaluation, like a serial evaluation, and then that one can publish and start again with the 2 case studies and the 3 case series, etc., for long COVID. But at the moment, we don't have any evidence. So if anybody is looking at treating patients for this, then I would suggest that you just contact me, that we work through the ethics issues and so on, that we can actually publish the cases in the literature and get the information out there.
Great, thank you, Jack.